We've been at this in North Carolina for a very long time. And the Division of Mental Health, Developmental Disability, and Substance Abuse Services played a key role. I passed the Albemarle building last evening driving home from meeting a few people for dinner, and was thinking about our first meeting there years ago. And around the table was Lee and me and Christy Straits-Troster, who worked with me at in the VA at our MIRECC, trying to do similar kind of raising awareness about the problems faced by returning service members, veterans and their families. Flo Stein and her husband Worth Bolton, and Mike Lancaster, who played a prominent role. I don't know if Mike's here today. Probably not. He's probably out bowling or something. But playing a prominent role in mental health. And you know, we were brought together by a number of different agenda, and I was thinking about that, thinking about the people in this room, many of whom I've known for years, and many of whom have played multiple roles in those years. So that was 2005. It was sometime before Christmas in 2005. The things that brought us together included our clinical interests, our academic interests, our personal interests and connections to the military and to veterans, but also real political issues, like there was a new election coming, and the governor was aware that veterans were a big part of the state of North Carolina. The economy of North Carolina depends on veterans and military in so many ways. And it was fascinating to see how all of these different ways of coming to the table eventually led to the conversation we're having today. And that's great. These agenda all drive us in the same direction, which is just being aware that around us are service members, veterans, and their families. When you do the math, there are 22.5 million American veterans currently. There's another 2.5 million serving in the military, so that's 25 million. And if you figure conservatively that each has 1.5 dependents, which is the conservative number, now you're somewhere 50, 60 million Americans. 1 out of every 5 Americans is either a service member, a veteran, or a family member living with one, and probably eligible for some sort of VA services. And if not VA services, the state's Commission for Veterans Affairs Services, which is really amazing. Because how often in our everyday life does anybody ever ask us, have you served in uniform, or are you close to somebody who has? Or knowing what to do with the answer. I always think the reason people don't ask the question is they wouldn't even know what to do with the answer. But conversations like the one we're going to have today, and which many of you have already been provoking in your own communities, in your own circles, are essential to getting that kind of recognition. Because one of the things we learn about veteran culture very early is that, like the military, the veteran and their family believe that somebody else is more deserving than they are, that civilians don't want to hear about this, and if they did hear about it, they wouldn't get it anyway, so why talk to them about it? And what will civilians think? They'll think you're asking for their sympathy, and I don't need sympathy. All those things that keep military members from ever talking about these things, or veterans with other people. And you know, I respect that culture. I think that's part of the strength of the military, the way they stick together, the way they think of others and not themselves. And look, if they didn't put the mission and their buddies above themselves, then the mission wouldn't be accomplished. So it's really necessary in a lot of ways, but the opportunities that are missed are tremendous. That'll be a sub-theme of what we're talking about today. So I thought it would make sense to provide some context around the VA, but to continue to try to connect it back to what we're doing here, because what we have here in North Carolina is a working DoD, VA, state, and community partnership. And no one part of that is more important than the other. These are my personal views, and it's always hard to know what the Department of Veterans Affairs thinks, but these are certainly things that I think. And I particularly always like Faulkner on these things. The past is never dead, it's not even past. Us sitting in this room is just one little bead on a long string. And there are lots of beads, and there are beads that go into the past and beads that go into the future. The important thing to remember, it's the same string. We're just tracing our path the way people in past generations have done. And hopefully we're creating a better string for the future, a better path for the future. I'm not going to read this whole thing to you, but just to give you a sense, when you think about the VA itself, we're constantly reinventing ourselves. And it isn't that somebody in Washington figures out the VA should do this, the VA should be that. It's a kind of a give and take between the public, the service members, their families, government agencies. All kinds of agenda come up that drive this thing. And it deepens with every generation. So that actually we could start at, I think it's 1663, when the Plymouth colony decides that, that anyone who's injured in the defense of the colony should be supported by the colony for life. But certainly 1776, before we're even really a nation, the first federal benefits for military veterans are developed as a practical issue. Look, Lexington and Concord are 1775, right? And so already there were veterans to be thought about. By 1811, you've got a lot of veterans of the Revolutionary War who have been serving in the Navy for 20 years or more. And the Navy says, well, you know, we're a culture. We need some place where sailors can go when they have no other home. And so the first federal facility for veterans is established in 1811, before the War of 1812. A lot more veterans after that. The Army takes 40 years to catch up, and I won't say anything about the Army versus the Navy, but the Army lifers don't get a home of their own until 1851. The first VA, anything even recognizable as a VA, is established in 1865. So the end of the Civil War, there are a lot of people who are not lifers in the military, but who have served in the military, often with their state militias, the equivalent of our National Guard today. And Congress and the country realize that a lot of these folks need help right now, and they begin to set up Union Army Volunteer Force programs, the National Asylum for Disabled Volunteer Soldiers, and that's in Togus, Maine. And the Togus VA is still on the site of that program and is the grandchild of that program. That eventually grows to 11 branches around the country, providing shelter and medical care, not for Confederates, by the way, only for Union. And then Congress in 1917, as we get into World War I, decides that there's going to be sweeping new medical benefits because the National Asylum was really a place to live. And sure, it had some medical capability, but it primarily they weren't hospitals per se. They were places for people to live, and they would take care of people as they aged. So, but 1917, we're going to have benefits for veterans, including life insurance, medical and dental care, vocational rehabilitative training, and prosthetics. Then by the next year, the Bureau of War Risk is founded. The Bureau of War Risk is really an insurance company for shipping into the combat area. And again, you see private industry. How are you going to get war materials into the combat area if you don't insure the shipping, whether it's merchant marine or just commercial shipping? So they create this giant bureau, becomes the world's largest insurance company. The building I work in, what's now VA Central Office, was actually built to house the Bureau of War Risk. And it had to be gigantic, and they were taking up real estate all over Washington. But eventually, functions for medicine and for veterans was put into this. It was actually not offered. There was nothing like the VA, so the public service marine hospitals provided those services. And really a melange of, you know, what are we doing and for whom? All mixed between different agencies. Only in the 1920s, though, does the VA really get up and running? And the reason has a lot to do with mental health. Thomas Salmon, who was General Pershing's psychiatric consultant around issues like shell shock, realized that when the war ended, he had thousands of American neuropsychiatric casualties, many of them still in Europe, and no way to bring them home because there was no place to bring them. These public service marine hospitals weren't big enough, and they weren't built for that. Thomas Salmon became the chief consultant for mental health because of his career before of railing against the state hospital systems because they were totally inadequate. They weren't treatment facilities, they were holding facilities, and they were dehumanizing holding facilities, and that was really what drove his whole career, is getting people to try to humanize them, but they weren't humanized. And ironically enough, and this is what happens if you get into government, he did come up with this plan to take the cadre of Army and psychiatrists that he had trained in the war. He convinced them to stay in the military, and he was going to send them to state hospitals all across the country. And the idea was, well, these veterans came from all across the country. I'll place these Army psychiatrists who know something about the problems these folks are facing. We'll create special awards and special services in the state hospitals. And the parents of these people said, Salmon, you're the one who told us we can't trust the state hospitals. You can't do that. So he started to agitate, along with a lot of other people, for a lot of other reasons, for a VA system. And the VA system is set up in the 1920s and eventually merged with the National Home System. And that begins the largest hospital building program in the history of the US, with 49 hospitals underway, already built by 1930 and more underway. And also a giant national scandal that almost brought down the Harding administration, but that's a long story. So, you know, we continue. The Army's National Cemetery System doesn't come into the VA till 1973, and VA becomes a cabinet-level organization in 1988, well within memory of lots of people in this room. The point I want to make is, the more we think about what our duty is to people who have served our country, the bigger the VA grows, the more complex it gets, until it's the second largest cabinet agency with a budget, I lose track of how much we have, but it's in the neighborhood of $200 billion a year, and about 360,000 employees. It's a very, very big program. And it's the nation's largest integrated mental health system. What do I mean by integrated mental health? It's something that North Carolina's been working on for years, the iCare program of having mental health and primary care integrated. Federally qualified health centers and the state's Department of Rural Health have been working on this issue as well, in coordination with our mental health programs. But even at Duke, and well, not in the Durham VA, but even at Duke, the psychiatric record was separate from the physical record. The problem lists were different. You could change somebody's medicine one day, and the next day they show up in the emergency room for something else, and nobody knows what medicine they're on because nobody ordered the psychiatric chart. The record systems were different. VA also is something that Lee and Flo have always trained me to do. Even though substance abuse system is in the name of the division, substance abuse is still very much different than mental health in the state. But in VA, they're totally coordinated with one another. It's all one thing. When you say mental health, you mean mental health and substance abuse. We'll talk more about the attributes of this, but this makes us unique and a model for the nation. Also makes us a target, because there are people who don't believe in big single-payer health systems. But we won't go into that today. Our top clinical priority is eliminating veteran suicide. Now, why is that? Well, because it's important. Is it the most important thing in the world? Right now, for us, it is, and it needs to be. But our secretary is also politically savvy, as well as administratively savvy. And he said, look, we need a clear focus, and the president tells me he's measuring me by the numbers of veteran suicide. And that's his metric for the secretary. So that's our metric. And I like that. You know, it's good to have priorities. As people I've worked with here know, I like a big tent, and I don't mind going in 3 directions at once. I'm doing it already in this talk. But the fact is that a large organization with, you know, almost 400,000 people working for it can't afford not to have clear priorities. Ours is eliminating veteran suicide, since there is no right number of veteran suicides. The first step in doing this was to guarantee access to mental health. We looked at the numbers that we had, and if it weren't for the VA system, nobody could have said that there were 20 veterans dying by suicide every day. We had to convince the Department of Defense to give us all the Social Security numbers of everyone who had served in the last 50 or 60 years, longer than that, actually. There's still one dependent of an American Civil War veteran getting VA benefits today. When I used to give talks a few years ago, we're 5, 10 years ago, there's only one now. But it gives you a sense when we go to war, it's a very, very long-term commitment that we make as a nation. So the first thought, when we looked at the 20, we found out that a lot of them were having problems getting mental health care. And of course, the scandal out of the Phoenix VA, the idea that people were waiting a very long time to get care. Now, it's not that people don't wait a long time to get care. There was actually a recent article in Psychiatric Services where they did a secret shopper program for psychiatrists, and they had secret shoppers calling psychiatric offices and asking for an appointment. And I believe what it showed was that basically 6 out of 10 times that call was never even answered. And that when people were answered, the average length was longer than 30 days to get a first appointment with a psychiatrist in other systems. But as of December 31st of last year, every hospital director of the VA had to sign basically in their own blood that if a veteran showed up for urgent mental health care, they would be seen urgently. That meant right now. They would be seen that day, and they would get a meaningful intervention in mental health and then be brought into our system. That's at our 144 medical centers. But what about the 1,200 plus community-based outpatient clinics? By December 31st of this year, each of those must make the same pledge, that there is no one who's going to show up that will be turned away. We will find a way. Now, there are different capabilities in different places, and our 1,200 plus community-based outpatient clinics were not developed for walk-in services, but they are now. And so this is one way we go about doing this. And we're doing that, we're increasing access at a point where demand for mental health services is rising. So if you look at, this is from 2005 to 2015, the rise in the percentage of veterans getting different services. And during this time, I'm not sure which of these points, the top one does? Well, I'm not pointing. It's okay. The fact is that the upper line, the 1.6 million, is the number of veterans who are getting mental health care. And you see how quickly that's grown from 0.9 million in a decade, whereas the total number of veterans getting care in VA has only risen from 4.7 million. Oh, that little button has only risen from 4.7 million, thank you, to 5.8 million. So the rate of needing mental health services has risen. Now, is that because people in VA have more mental health problems than the general public? And the answer is no. They have better access to mental health than the general public, so they access it. 28% of everyone in VA care in any given year is accessing a mental health service. The rest of America, statistically, would do the same if they could access mental health service. And it's not the same 28% in any given year. We're not talking primarily about the seriously mentally ill who have chronic issues. We're talking about everybody: depression, PTSD, anxiety disorders, waxing and substance abuse disorders, waxing and waning. Another reason it goes up is that we ask every veteran every year about depression, PTSD, traumatic brain injury, suicidality if they score positive for PTSD or depression, and for alcohol abuse. We don't screen for other substances yearly because there are no good screens for other substances. And if somebody in this room would like to invent one, that would be really nice. Early identification, screening, and intervention. We do this also in primary care. So years ago, primary care doctors were notorious for not recognizing depression, and that became the place to start in trying to get primary care mental health integration. But in VA, as of 2015, 13.5% of everybody being treated by VA had a depression diagnosis that was documented during a primary care visit. So the primary care teams are paying attention to depression. And what's even better is that about a third of them received care from an integrated mental health provider who was part of that clinic. And even better, 71%, the vast majority, were getting their depression documented exclusively by their primary care providers. And they were being treated by their primary care providers, because primary care providers don't have a lot of time, but you only have to show them something 10 times before they start doing it themselves. So whereas we build mental health staff right into primary care, and this is such an important issue, even when we first set up, say, in Wilmington, our community-based outpatient clinics, The people who developed that put the mental health like down the street because they couldn't find a place big enough to have mental health and primary care in the same building. Well, we'll put mental health down the street. So what happens is you diagnose depression in a primary care clinic. Oh, walk down the street. Oh, nobody ever walks down the street. Come back on Monday. Nobody comes back on Monday. All of our clinics are now designed to physically incorporate mental health into primary care, but to teach the primary care providers to do this for themselves as much as possible and only use the mental health asset when you have a more complicated case, and only send people to the mental health clinic when it's beyond the scope of the integrated unit, so that we're actually using our assets more wisely. And so that more people keep their appointment, because their appointment is come meet my colleague down the hall, or let me ring that person, they'll come right in the room, and you don't have to walk down the hall under the sign that says mental illness. You know, I'm not saying there should be a stigma, but there is a stigma, and making people walk down that hallway is a great way of never seeing them again. And that's a terrible waste, especially when you're talking about suicide prevention. By the way, so what is suicide prevention? One thing I want to have clearly in your mind is that every time we offer good care of any kind, mental health or primary care, we are preventing suicide. Every time we engage a veteran in VA, we are preventing suicide. But the same in engaging them in a federally qualified health center. Every time one of your programs, maybe that isn't veteran-centered, engages a family member and identifies them as the family of a service member or a veteran, somebody with having housing problems, somebody dealing with a family member with substance abuse, somebody living in a basement who won't seek care, you are preventing suicide. There's an upstream and a downstream part of this, and suicide prevention is not throwing life preservers. By the time you're throwing life preservers, it's too late for many people, and you can prevent that. We also treat substance use and PTSD in primary care. And ideally, we want to treat 70% of all mental health issues in primary care. I don't mind. We'll always have plenty to do in mental health. Right? We're never going to be bored. So we have this full range of services. I mentioned 145 VA medical centers, 1,233 community-based outpatient clinics, 300 vet centers, and many of you know the vet center. Whenever I see Gary, I always think of the vet center in Fayetteville. Gary started out there. He's now the VISN suicide prevention coordinator, and he brought a ton of stuff to share with you for later. And be running one of the small groups. We also have 80 mobile vet centers. So when Houston floods, the mobile vet centers drive down to Houston and park in parking lots and Walmarts and whatever, all have satellite communication systems, can coordinate with other disaster response people, help veterans, but frankly help anybody. This is part of our mission as well. We have VA working on college and university campuses. I'm not sure if Moses Gloria got up this early in the morning from the Vet Center in Raleigh. Moses has been doing great work with state for years. We'll talk maybe more about that later. We actually have 1,078 peer specialists as of Friday. These are people in North Carolina, again, a leader in training them in community colleges. You can become a certified veteran peer support specialist, which means you have a lived experience of a mental health problem and you've taken a certified course, usually in a community college or college. It's about 50 hours of training, at the end of which you are really prepared to engage and point people to the right place. And these peer specialists, again, VA employs them in mental health and primary care. We need to employ more of them in homelessness. We need to have more in the community. The Vet Center in many ways has always been a peer-to-peer program. I think it's still about 70% of everybody who works in the Vet Center is a combat veteran. And the Vet Centers are for combat veterans, no charges. Don't even have to enroll in the VA to be in them. And parked in nice little community shopping malls all over. Although I probably couldn't find the one in Raleigh anymore. I heard they moved. But Greensboro, Fayetteville, now I'll get lost, so I'll keep going. The Veterans Crisis Line, this is the life preserver. And again, we get to be in the newspapers, you know, calls rolled over, whatever. They don't roll over to somebody, you know, living in a bungalow in Connecticut. They roll over to a different call center, but they do roll over. But we are now well below the national standard. We have tripled the number of hubs for the Veterans Crisis Line. We've brought in very good professional business people. You know, one of the lessons you learn working in the VA is that mental health people shouldn't be running a call center. That running a call center is a special technical issue. So we should have people who answer the phone who know something about mental health, but the people who run a call center should be business people. And you know, this has really helped us up our game significantly. So we're now well under most days of there are bad days, but most days of the week we're well under the or above, if you will, the standard for answering calls, timeliness, and less than 1% rollover. We're now, actually, I saw a presentation by the people who run this on Friday. We're over 3 million calls answered since the center was invented in July 2007. We've now dispatched emergency services to people's homes or to mountaintops in Tennessee, literally, over 80,000 times. About 400,000 referrals to local suicide prevention coordinators. We have 400 of them in the VA system. And their job is to welcome people at the door, to call if they don't show up after calling the vet center, or rather the call center, to be training our own staff and training community staff to do at least 5 trainings per month in and outside of VA, because teaching about suicide prevention is essential to preventing suicide. We have a predictive analytics program called ReachVet. What we've done is we took we took large numbers of veterans who died by suicide and ran their electronic health record backward and looked at what were the predictors in the electronic health record of people who died by suicide. All that really tells you is association, doesn't tell you cause. But it turns out that there are many factors associated. Some are administrative, how much money people make, who they live with, where they live. Some of them are medical, what diagnoses they have, things like chronic pain and substance abuse. But what we've done then is we've then looked at other people's medical records, everybody's medical record in the VA. And having the world's largest electronic health record, this is a very powerful tool. So now what we do is we have coordinators at every medical center who get a list, constantly updated, of everybody in their medical center who might be at risk for suicide. What's really interesting about this is it doesn't just predict who's at risk for suicide, but who's at risk for all sorts of bad health outcomes. That there are certain common factors that make people vulnerable, and suicide is only one of those vulnerabilities. Is this about self-care? Is it about overall health? We don't know, and it doesn't really matter right now. Let somebody else do that research. We have a practical tool which we've chosen to put right to work. I was actually at the table with the secretary when this was being presented, and the ask was, let's do some pilot studies in a few larger areas to see if we really can do something with this. He said, you're telling me you got a tool that predicts suicide and we're not going to use it? I want this used in every hospital. In 2 months, I want every hospital to have a list. And so we talked them down a little bit. So how about we just give you the very smallest number, like 0.1%. And those people are like 80 times the risk of suicide of the average veteran. And then we'll build it out, because we don't want to create a system that we don't know if it'll work or how to use it, or somebody's asleep at the switch. We don't know if the coordinators are really going to be able to do their jobs well. And we also don't know what to say to these people. What we are saying to these people, it turns out to, I think, be very helpful, is not, hey, you're going to commit suicide, like that Tom Cruise movie. We know the future, and this is what you're going to do in it, and so we're going to deal with it now. What we say to the people is, we've reviewed your chart, and we think you're somebody who might benefit by enhanced care. And we'd like to sit down with you and talk to you about your health care and what you would like to do, and we have suggestions of what we'd like to do and come up with a plan. And rather than veterans saying, what, you think I'm crazy? You're going to throw a net over me? You're going to take my benefits away? You're going to tell the police, what are you going to do? People say, oh, you took the trouble to figure out that I might need some help? That's really nice. So yeah, I'll meet with you. And it's working really well. Now, can we prove that we're preventing suicide? No. But we're flexing our muscles, we're trying our tools, we're testing our originality, and we're using our resources. And this is a great challenge, and that's why it's a great adventure to work in the VA. I think we're going to do something valuable, and we're more than happy to share these analytics with other groups. When I think of what NC State could do with this, I'm looking forward to sharing these analytics with other groups. We're actually testing these same algorithms in large populations in private health systems to see if they can have identify the same kinds of cohorts and what their interventions would be. Increased mental health services for women veterans. Women veterans are at several-fold risk of suicide of the average American woman. And probably the main reason for that is they choose firearms as the way to die by suicide. When you attempt suicide with a firearm, you're 90% likely to succeed. When you attempt suicide with poison, which is the most common thing that women use in the general public, you're only about 10% likely to succeed. So it's not necessarily that women, veterans, are more likely to be suicidal, although they may be. Having PTSD and depression, they may be. But they're certainly more likely to die by suicide because you can't unfire a firearm. That is a major issue and creates special kinds of interventions, special outreach, special education. You know, my daughter lives in Pittsburgh, and one night we were out having dinner, and we walked down the mall we were eating dinner in, and there was somebody who was basically had a new store that was selling firearms to women. And we went in, and they offered to enroll us in the course. And, you know, actually I was kind of interested. I didn't have time. But, you know, firearms for women, it's like Virginia Slims. You know, you come a long way, baby. It's the same thing. Since most of our neighbors answer the door with a firearm, I've often wondered if she shouldn't own a firearm, but that's a long story. We're not judging firearms. We're trying to make them safe. The expansion of telemental health, we'll talk about that in a minute. And coaching to care is something I want you to know about because, you know, people may know of the Clay Hunt Act. Clay Hunt, who died by suicide after serving in a deployments to Iraq and Afghanistan with the Marine 27 battalion. I've had multiple conversations with Clay Hunt's mother. And also, people may know Daniel Summers, whose parents have been crusaders for suicide prevention for veterans, and wrote a suicide note that has been on the internet and really very, very powerful stuff. And his parents have become good friends. And in both cases, they had no idea that there was a phone number already existing when their sons were struggling that they could have called that could have walked them into care. Coaching to Care, if you call that number, it's live about 12 hours a day with offices on the West Coast as well as the East Coast. You can speak to a social worker or a psychologist in the VA who will teach you motivational interviewing techniques that'll help you motivate the veteran that you're concerned about. They might be your son or your father. They might be somebody who works next to you on an assembly line. Or you might be their boss or the employee assistance program or their lawyer. You just don't know how to help them get help. But Coaching to Care will assign you a coach who will be your coach until that person gets help either in VA or in the community. We don't care where they get help. We just want to get them into help. And it's incredibly powerful. Part of it's based here in Durham. Well, we're not quite here in Durham, but close enough, right? So I want to make sure people know about that. And it's free, of course. This is the call, the VCL. That phone number, 1-800-273-8255, takes you actually to the National Suicide Prevention Call Line, which is run by NIMH. But we have a specialized veteran part. That's why you have to press 1 to get to it. Won't show you any videos, don't worry. Telemental health. I like the slope of the curve, but this is still pathetic. The VA is the largest provider of telemental health in the country, maybe in the world, but we're not nearly what we could be. In the last years, we've set up 10 hubs, and we made it entrepreneurial. We told some of our networks, and we're in VISN 6 here, we told our VISNs, you could make money in VA. You can make money in VA. You get more of the share of the national allocation for VA health if you treat more people. And we said you could treat more people if you would offer telehealth services to VISNs that are not proactive in creating telehealth. And you could sell telehealth services. We now have on the Federal Register our intention to use federal supremacy to do something no telehealth program in the country can do, which is treat any veteran from point to point anywhere in the nation or in Guam or Puerto Rico or any American territory. Or for that matter, veterans who live south of the border in Mexico, veterans who settle in Germany after they do their service, say, in Germany, and some people settle down there, we can treat them there. And also what's really cool about this is the clinician could be in their home. They don't have to have even an office or a parking space at the VA. So we've just opened a parking space and an office for some veteran in Durham, which is so landlocked, you can't park your car and you can't find an office sometimes. So rather than build new hospitals, we create virtual hospital systems. And we simply coordinate these systems from all over. And since we have an integrated health record across the nation, we can do this and not lose people. So the numbers, the overall numbers are pathetic. 380,000 encounters, to date. We're going to be doing a lot more telehealth. A number of other tools and outreach issues, and a lot of it's partnerships. And I've got to say, my experience in North Carolina was wonderful for getting into VA. A few weeks after I got into VA central office, the new secretary, that was right after the crisis, new secretary set up an office of public-private partnership, which has since entirely turned over. But we started creating other partnerships. For instance, we're now working with Johnson & Johnson. And if we have time at the end of this, I'll show you the public service announcement with Tom Hanks, which with Johnson & Johnson's help and also Marvel Communications, we were able to get Tom Hanks to do a PSA for us and launch it on Fox News a couple of Mondays ago. But we do military culture training. Actually, the VA and DoD started this idea of doing military culture training, partly inspired by the work that Bob Goodale and had started in Citizen Soldier here in North Carolina. That was the model of what you do. But then it became so overblown, it became an 8-hour training, and then it was put behind a firewall at this VHA train site. And I've got to say, if you want 8 hours of free CEUs and really good training, take our military culture training. There it is. Take our military culture training at this site, and that's great. But for a lot of people, they're not going to have 8 hours to do that, and they don't need the CEUs that much. Psych Armor is a nonprofit that grew up just in the last few years out of San Diego. And their mission is to sort of fill the space between DoD, VA, and the community when it comes to educating people about military culture. Their latest product is called 15 Things You Want to Know About the Military in 15 Minutes. And people are more likely to take the 15-minute training, and it's good. And it's written by people who used to work for VA. And it's extremely good stuff. And then if they got that, I'd be happy. But if they then wanted to spend time in their spare time to do the 8 hours, wonderful. But that's important stuff. We have handbooks for people who want to work on campus. The VA administers the GI Bill. We're paying for thousands and thousands of veterans to go to college. It's a great place to engage with them. Plus, they have certain challenges at college. So we want to engage them so they succeed. There's no sense sending somebody to college to fail. We want to be sure that they succeed. And it's a critical time for them. So we have the VITAL program. We have a campus toolkit, which anybody can read. You don't have to get there were no more VITAL grants there were to set up these centers, but universities, colleges, community colleges can do this by themselves. And the Student Veterans of America, who are on virtually anybody here from Student Veterans of America? Yes, yes. Are on virtually every campus, can be the nidus for doing that. You get a few interested faculty members, maybe some VA staff will volunteer some time, and you can do this virtually anywhere. Our community provider toolkit is run out of the National Center for PTSD. I highly recommend this website. If there's anything you ever need for information about treating PTSD or depression, how to work with the VA system, how to get benefits for a veteran, it's all at the Community Provider Toolkit. And it's free, it's in the public domain. And my friend Dr. Shannon McCaslin, who I'll see in Chicago in a couple of days, will personally answer your questions, and she's very, very nice. If you have any questions about it. We are doing these annual community mental health summits, and the folks at Durham VA and Karen Getz and that team are the people who actually roll up for the whole nation out of Duke Epic, the VA community mental health summits. So please take part in those when they're happening in the VA nearest you, and they do in every VA in North Carolina. We have web-based self-help tools for veterans. It could be things like managing anger, parenting skills, problem-solving skills. These two are suicide prevention. And you can log on, you can assess yourself, take self-assessments. All this is off the grid. You don't have to be enrolled in VA. Your use of it is entirely anonymous. Nobody's collecting data on you. And the idea is to help families stick together and keep people from being homeless. And I believe these are very successful tools. And mobile apps like the PTSD Coach. We have our own app store. Quality, VA quality is good. Veterans actually rate us at very highly. And the RAND Corporation, but we paid for this study, so I myself am always iffy about it, but said that we were 30% better on objectively measured mental health measures than the private sector back in, but that was back in 2011. We're building in measurement-based care so we can tell if veterans think they're getting better. You know, as people tell you more and more, we don't care if you have the right processes, we want the right outcomes. And so we need to ask veterans. It's hard because we have this firewall that's built to prevent anybody messing up our medical record system, but that makes it difficult for veterans to enter their own data. But we'll get there. We have a lot of people to fight with about this, but we'll get there. And we're piloting this at over 100 sites across VA right now. Let's see, academic affiliations. One of the things that the modern VA after World War II did is to involve universities and medical schools. And at this point, the idea then was to make sure that VA had access to trainees, to research dollars, to faculty, to supplies, to surge capacity. If we went to war again, that we could use the university hospitals. And we do under the National Disaster Medical System. They all become federalized. Thank goodness we've never really had a full-scale implementation of that. But we're prepared to do it, and it's part of the idea of building the VA after World War II. But it's also made VA absolutely integral to medical education. Most physicians have at least some of their training in VA, nurses, voc rehab, speech pathologists, audiologists, podiatrists, optometrists. If anyone ever tried to get rid of the VA, they would have to dismantle the entire health education system for the United States to do it. Now, we didn't build that for that reason, but it's true. And people need to think twice about that because we do and pay for a lot of this training. Why? It's in the national interest to do it. Veteran experience, we're doing these calls. Frankly, a lot of veterans are annoyed to get these calls, but we've been collecting data quarterly, and not enough data yet. That's new to tell you exactly what we're finding. Other tools I want to tell you about, make the connection. So say you ask if somebody's a service member, but you really don't want to ask this question because you don't know what to do. They say they're a service member, they're a living one, but now I don't know what to do. Is this a history test? Am I supposed to know all about veterans or where to go or what they're eligible for? It's very complicated. Maybe I shouldn't ask. If you ask the question, all you have to do is give them this website. Just say maketheconnection.net. Over 600 veterans have volunteered to tell their own stories on this website. And what happens when you go to maketheconnection.net is it says, you know, well, hello, veteran, you know, what branch of the military did you serve in, when did you serve, what'd you do, were you deployed here and there? And based on your answers, up top of the 600 vignettes, maybe 8 of people who are very much like you. And the message is almost always the same. They are individual stories, volunteered, these aren't scripted. Veterans who wanted to share their story with other veterans because they thought it might help another veteran. That's military culture at work. That's the way veterans are. And the story always boils down to the same story. I came back, I didn't think I had a problem. I thought everybody else had a problem, but I didn't have a problem. But things started to go badly, and finally it occurred to me, maybe I should check this out. And I did, and it helped me, and maybe it would help you. And that's from a veteran to a veteran, not a doctor, not a boss, not even a family member. A veteran to a veteran is a much more powerful intervention. 11 million website visits, 16 million views of these videos, one of the largest Facebook communities in the nation. This is highly successful. Where we don't really want to engage people, but we need to, is veteran justice outreach. When people are arrested, when people are already in prison, when people are within 6 months of getting out. You know, the vast majority of veterans are related to crimes stemming from homelessness, not violence, not meanness, homelessness, vagrancy, public intoxication, things like trespassing. And if they leave prison or jail, coming in homeless are most likely to be homeless again. And we have Jeff Doyle's here. I just saw him a minute ago. I lost him now. Our homeless, yes, all the way in the back. Our network, VA network homeless coordinator lead. Incredible work in North Carolina. A lot of good meetings here in the center. We've done a great job of housing 33,000 veterans in case management, 63,000 housed. And one thing that's unique about VA is that we will house the entire family, not just the veteran. And it's permanent free housing in partnership with HUD, Housing and Urban Development. SMI Reengage, we chase the people who drop out. People with chronic mental illness, we will go back to them and try to recapture them. And we've been about 24% successful within 4 months of getting people back into care. Most other systems have no reason to do that. But one thing about the VA is we try to do the right thing for the right reason, and we're funded to do it. The other unique thing about the VA is we really do take care of the whole person. Their housing, their family, their education, their job. These are all part of what we do. Frankly, all health systems should do this because these are the real determinants of health, right? The social determinants that really determine your health outcomes. Your genes are only a small part of it. And, you know, as much fun as it is to talk about genes, we are not, you know, Gregor Mendel's pea plants in the garden. Our genes are much more complicated, and they don't determine our future. They only influence it. Most of the variance is determined by having a job, by having a roof over your head, by having a spouse, by having a relationship with your children. Those things determine your health. But health systems mostly aren't built to do that. So we'll keep paying for, you know, a procedure or a pill and consider that health care. That is not health care. That's only a tiny bit of it. And we're trying to model what health care really is and could be for everybody. Let's see. Veteran suicide. So the VA conducted the nation's most comprehensive analysis. So as I said, we got all these Social Security numbers from 55 million people. No, more than that. We got all these Social Security numbers from everybody who served in the military for like the last 80 years or so. And then we matched them against everyone who died in the United States. And I forget over how many years. And so we identified all the veterans who died, and then we looked at how many of them died by suicide or anything that might have been suicide, which is where we came up with the 20. This took years to get just the people to give us the data. And then we were doing it ourselves when like the few states that would share data with us, but then we were able to get all states and territories. And that's when we went from 22 to 20, because we got much more complete data, and it was 20 veterans a day. That is not a victory. That's just statistical. That's not better. You know, it's still a national tragedy. But at least we know the numbers, and we know what number we have to change. And we'll know when we've changed it, because we've got a baseline. If you look down at North Carolina, you drill down to North Carolina, 249 North Carolinian veterans died by suicide in 2014. That is an unacceptable number, and you see that mostly male. Women may be serving at 20% in the military, but women veterans are still about 12%. And that reflects mostly the younger generation of women. If you look at veteran suicide in North Carolina, it's not really any different than veteran suicide across the country. No better and no worse. If you look at overall deaths in North Carolina to suicide, veterans as a group are significantly higher than the national rate of suicide, or non-veterans in North Carolina. What is VA doing about suicide prevention? Well, in VA, and apparently a lot of the government now, if you've got a problem, you have what's called a sequester. You basically lock people like you guys in a hotel or a conference center like this for 4 days, and you don't get, it's like EST. You don't get out until you solve the problem, right? Or at least you have a plan. And so they locked us up in a place for 4 days, and we came out with 150 things we were going to do. But you can't do 150 things. And we then kind of sat around and said, well, what really are we doing? What are the major clusters of things we need to do? And within those clusters, what are we going to do in each cluster that's measurable, that's feasible, that's sustainable? And this is where, again, it's good to have business management. Doctors and Mental health specialists and researchers are wonderful, but they're not good at focusing, at least not mental health people. And that helps you be a better mental health person, but it's not good to set up a national program, not by yourselves. But these are the big buckets. Improved transition. You know, many of you have come to realize and develop new systems of care, realizing that when someone leaves an inpatient hospitalization, whether it's a medical, surgical, mental health, those first few weeks, the first 2 weeks and really the first 4 weeks after you leave the hospital, are when complications can come up, relapses come up, suicide for people who leave the hospital, say for depression or anxiety disorders or substance use, go up. Overdoses, overdose deaths, whether accidental or on purpose, go up. So we've all been really working over the last decade or so at developing transition. You know, how often are you going to get a call from the hospital or be visited and have outpatient care? How long do you have to wait for your first outpatient appointment? Because this is how you prevent those problems and, you know, the overuse of the emergency room, the readmission rate. But leaving the military is similarly a dangerous time in just the same way. You know, we've known since Vietnam that the rate of death from all causes increases in the first 2 years after you get home from a deployment. From all causes, medical causes, car accidents, and suicide. Some of those medical or car accidents may be suicide and not known to be suicide, but it really doesn't matter. We are trying to work with DOD, and they've been very receptive at a 1-year transition out of the military. Now, it may begin during your military service, but it has to be more than the hour and a half or so we get in the Transitions Assistance Program, the TAPS program, you know, where we hand out brochures and we talk at you the way I'm talking to you now, and nobody ever really listens because everybody wants to get out of the military. Or as Bruce Capehart once said, coming back from the National Guard from a deployment in Afghanistan, people are only thinking about beer, sex, and pizza. So, you know, they're not listening to what's the phone number to call the VA crisis line. And they forget there is a crisis line by the time they get home and might need one or might want to refer to their buddy to one. There was something, I don't remember what it was. Oh, well. We have to build a system, and it has to involve the family members, because family members will remember this more. I know my wife would pay attention to this stuff more than I would. And my children probably would too. So how do we build that system? And we're just in the early stages of what does that look like. But the military, the administration, and the VA are all busy figuring out transition at a 1-year level. It's different than just going to like reverse boot camp, but the idea of it is very similar. It takes a long time to train somebody to be a soldier, a sailor, a Marine, a coastie, an airman. It takes a long time to train people. And then, you know, even if you train them with live ammunition coming over their heads at Fort Bragg, that's not the same as actually being in a combat area. That's different. And your reflexes get sharpened, your view of the world and of yourself and the people around you get sharpened. Nobody trains you to be a civilian when you get out. Nobody even trains you to be in garrison when you come back and you're still in the military. And a lot of problems pop up at those times, which is one reason why we have 500,000 people with other non-honorable discharges among veterans who until recently weren't eligible for VA services. But we've decided, since that group is actually at increased risk for suicide, we're going to treat those people urgently. 90 days of care and re-up for another 90 days, and frankly, re-up for another 90 days if we don't get them into the right place, both health-wise and into the right follow-up care. We're not going to drop anybody or let anybody get lost. Know all veterans. Of the 20 who die, only 6 are using VA health care. The other 14 are not. We don't know them. We can't reach them. Who are they seeing? They're seeing you and the people in the services that you run. But most of you don't know that they're veterans. And therefore, you can't tell them all this lovely stuff that we could do or would do, and you can't send them to the State Division of Veterans Affairs for the special scholarships for their children and the employment opportunities for their spouses and the retraining educational programs for them because you don't know they're a veteran. And I suspect people in this room are doing much better at that, but your partners aren't. And that is something we have to work at. So know all veterans, and then focus on the levers that we can pull for those veterans that will have the biggest impact in the shortest period of time, and which again are feasible, sustainable, measurable. So we know if it's working and can do something else if it's not. Partner across communities. Again, you guys are a perfect example. And North Carolina has done better than any state I know. And, you know, SAMHSA, and we have representatives of SAMHSA here, did a wonderful job of creating the Paving the Road Home program. All 50 states and the other 4 territories involved building systems at the state level, because the state level is the natural level. You got the National Guard, you've got the State Division of Veterans Affairs, you've got the Veteran Service Organizations at the state level. The state is the right level of organization for working with veterans and their families. But I'll tell you the truth, of all those states, very few of them reached critical mass, and very few of them could still have a program like we have in North Carolina that you could point to that's ongoing, the way the work group is ongoing and meets every month. And if you aren't going to those work group meetings, you shouldn't. I hear they're being streamed, so you don't have to drive from Asheville to Raleigh to do that anymore. And I really recommend you take part in that and be part of that community. Lethal means safety. What the experts in suicide prevention tell us is that if we could reduce access to firearms in the first 10 minutes that somebody gets the idea of dying, that would have the single biggest impact of suicide of anything else. This is the reason the VA has given out well over 2 million gun locks. We're not against weapons. We're not taking any side on gun safety, in gun restriction. That's not what we're interested in. We want people to have that 5 minutes to say, how the hell do you get this lock off this thing? You know, and that's all. If they had 5 minutes, people would live. Having had a lot of experience in emergency rooms when people woke up from overdoses, I have never met a person who said, I want to die now. There are such people, but I've never met one, so they're rare. People need the chance to rethink this. And if they had the 5 or 10 minutes, we did a massive study, DOD, VA, several university folks, on this Marine 2-7 battalion that Clay Hunt was a member of. They have about a 4-time rate of increased suicide over other Marine units that have served in deployment. And in fact, we're doing a special project with them. We're training 21 of them to be peer support specialists, and then we're going to send them out to meet with their buddies all across the country, 1,280 of them. And this is going to be a great adventure. It's a non-clinical, non-research adventure in suicide prevention. We'll see if it helps. I think of it as reverse contagion. When you read in the New York Times, as there have been 3 articles on this unit, that you are a cursed battalion and you're all going to die by suicide, then it's a self-fulfilling prophecy, which we tried to explain to the reporter, but he was too busy writing about what a rotten job we were doing. But, you know, somewhere in between is the truth. And it certainly focused our attention on this. The bottom line is that when we studied the 2-7, we saw that most of the suicides are at the intersection of an acute relationship breakup, being intoxicated, and having a loaded weapon within arm's reach. Those 3 things together kill people. 2 out of 3, maybe not. So how do you do something about that? We can't take weapons out of people's homes. And as I say, we don't want to, but we could give them a free gun lock, so they have to figure out. You know, we could teach them to keep them unloaded. It's hard, but we could. I know we'd save lives. It isn't easy. And improving access, and we've talked about that at the beginning. So, with a little time left for questions, we're now partnering with the community, with thanks to, and I'll close with this, the Be There campaign is going to be year-long. And by the way, the President, on November 1st, did proclaim something which we put into his mouth. You know, sometimes you can make the President say things. Who would have thought? The idea of having Veterans Month. And this is really inspired by the fact that if you go to Canada, Great Britain, people wear poppies. Everybody from the Prime Minister, the newscasters, people on the street are wearing poppies from November 1st to November 11th. And we thought, well, why not have Veterans Month in the U.S.? So this is the first Veterans Month. Whether there'll be another one, we don't know. But to me, it's a lead-in to the first century. The 100th Veterans Day will be in 2018. And we want to use this whole year as a lead-up to that. And the motto, the slogan we're using, SAMHSA, DOD, VA, is Be There. And now we're working with our community partners. Oh, by the way, this is the building where I work. I'm on the 9th floor on the I Street side. It's that one facing away from us. And the point here is that the VA is always being built. You know, the building may be done, kind of, but the VA is always being reconstructed, and it's a dynamic thing. It's not a static thing. And the same here in the state of North Carolina. Helping veterans understanding their issues are static, and you're not going to get it out of books. I always like this quote from Sir William Osler, who founded Johns Hopkins Medical School in its current shape and invented American medical education. He who studies medicine without books sails on an uncharted sea, but he who studies medicine without patients does not go to sea at all. We have to follow the veterans. You know, don't even listen to me. Follow what your veterans are telling you and do that with them and figure out what to do. I want to take a moment, just if I can, and I think I can, to show you this thing, and then we'll pause for questions. This is our PSA.
In the fabric of America, they are the toughest threads, our bravest, and most selfless. They raised their hands, stepped forward, and served for each other, for you, and me. One of the first things they learned was the code that every service member lives by. Leave no one behind. Now all of us need to live by it too, because some veterans are being left behind. 20 of them take their own lives every day. Why? It's not simple. It never is. What matters is that we're there for them, just like they were there for us. A handshake, a phone call, a simple gesture make a big difference to a veteran in crisis. Learn how to be there for a veteran at BeThereForVeterans.com. Honor the code. Be there. Leave no one behind.
Even though that website doesn't say VA on it, it is a VA website. And no matter who shows this thing, Johnson & Johnson can show it, we'll license it to other people. Anybody who shows it, it'll drive people to our VA website. But you see, the real spirit of it is that everybody can play a role and needs to play a role in preventing suicide. Those upstream things are better than the downstream ones. Except to say, we have online what's called SAVE training. If you Google it, it's, you know, there's usually it's an acronym, and it has a period after each, SAVE with periods. This training can be done with lay people. We're trying to share it. Gary, I'm sure, will connect you to SAVE training and talk more about it in his groups. So I hope people will think about this, but it's ingenuity. Don't sit around waiting for the VA to do this for you, because we might do it and we might not get around to it and we may not know you need it. Figure out what you want to do, what works within your sphere, no matter what it is you do. There's something you could be doing to help prevent suicide. And you get the rest of the day to figure that out. So thank you very much.